Hey team, welcome to the MMOA podcast. I'm Macy Bolt, outpatient PT and TA with the older adult division of ICE Physio. Today we are going to be discussing the management of orthostatic hypotension in the context of a patient on my caseload. We are going to get into what orthostatic hypotension is, how to test for it, how to manage it in the short term, and what the long-term goals are with these folks to get them functioning with fewer symptoms. So, orthostatic hypotension is defined as a drop in blood pressure of greater than or equal to 20 milligrams of mercury systolic or 10 milligrams of mercury diastolic during a transition to standing or a more upright position. So that could also be a supine to sit transition. Physiologically, what's happening during that transition is that blood pools in the legs due to gravity, which causes a decrease in the blood flow returning to the heart, which then reduces cardiac output temporarily. Normally, what happens is the body responds through the baroreceptor reflex, which increases sympathetic tone to increase the vascular resistance peripherally to level out the blood pressure during that transition. So by increasing the peripheral tone, it forces blood back to the core. Then what happens if someone has orthostatic hypotension is that the baroreceptor reflex is not functioning optimally. What can happen then is a delay in that blood pressure recovery because we're not getting that increase in peripheral vascular tone. And so that delayed recovery elicits a lot of the symptoms that many of us are familiar with when it comes to postural hypotension, which includes dizziness, lightheadedness, feeling like you're going to pass out or presyncope, nausea, headaches, feeling of chest racing or head pounding. All of those things can really fall under that category of symptomatic orthostatic hypotension. So the prevalence of OH in our older adults is estimated to be between 30 and 50%, which is huge. That tells you that this is happening to a lot of folks, and so we need to be looking for this in our older adult population. That being said, it's not necessarily something I'm testing every single one of my patients for. What I'm doing is I'm listening to signs and symptoms that my patients are reporting, and that indicates to me whether this is something I need to screen for or not. So clinically, the things that cue me in that I might need to dig into OH is reports of nonspecific dizziness that the patient can't quite describe, a feeling of unsteadiness or lightheadedness with transitions, feeling like they're going to pass out, headaches, tunnel vision, nausea, and then thinking about things like polypharmacy and other comorbidities in general. If this patient has a lot of comorbidities on board, including diabetes, cardiac history, kidney issues like renal failure, Parkinson's disease, certain types of dementia, especially Lewy body dementia, those are things that kind of add to the bucket of risk for orthostatic hypotension. And so that cues me in that that is a patient I probably should be screening. So that being said, that takes us to my friend Jim, who is 77 years old. Jim is the kind of patient where when you open up his medical chart, you have to scroll and read for about 5 minutes before you can really capture the snapshot of his entire medical history. He is very medically complex. He is 3 years post-kidney transplant with about 35% of his overall renal function at this point. He is on a chronic chemotherapy regimen for CML or chronic myelocytic leukemia. And in the last 2 years, he has had a triple bypass. That happened the day after his kidney transplant. And then last year, he had a stent placed in his widowmaker in kind of an emergent fashion. He also has type 2 diabetes, has diverticulitis. And the reason I bring up the diverticulitis is because that impacts his hydration and nutrition significantly because he does not feel well when he eats. And so he limits his intake significantly. So Jim came in to see me with the general referral of falls, gait, and balance concerns, as well as some nonspecific dizziness. Of note, I am someone who sees a lot of patients with dizziness. Orthostatic hypotension is some of the lowest hanging fruit in screening and is so often misdiagnosed for vertigo when really The dizziness that's produced with orthostatic hypotension has nothing to do with the inner ear at all. So during our evaluation with Jim, we went through the basics, which really includes discussing when he gets dizzy, how long it lasts, and what it feels like. Those are kind of the three questions that I always start with dizziness, because that rules in and rules out and kind of helps me guide where my testing goes next. So one thing I always do, this is a tip from Jeff Walters, who's kind of a vestibular guru, is I always ask my patients to describe their dizziness without using the word dizzy, because most people are like, well, it's just dizzy. But to other different folks, dizzy means a lot of different things. It can mean spinning, it can mean unsteadiness, it can mean lightheadedness. So I ask people to describe it without using the word dizzy. Jim described his dizziness as a whooshing feeling and a feeling like he was going to float away or pass out. So I clarified with him then that there was no spinning sensation involved. And he denied a spinning sensation. He also told me, which is really important, that this occurs when he stands up after being in his chair for a while and when he wakes up first thing in the morning. At this point in time, Jim was pretty inactive and spent most of his day in his recliner, except to get up to use the bathroom and go to the kitchen and the garage, because he was feeling so unsteady and so just kind of yucky anytime he was up and moving. He also noted that symptoms were always worse in the morning after breakfast, when he was more tired, and symptoms would last until he sat back down and rested. So at this point, I have a pretty solid suspicion just from talking to Jim that this is not related to his vestibular system and has a lot more to do with his blood pressure. But I ran him through vestibular screening anyway, because if that stuff is underlying, it can really kind of complicate the course of care. So I screened him with Dix-Hallpike testing, head impulse testing, and a modified CATSIB, which tests kind of the sensory integration systems. None of that brought on his familiar symptoms. What did bring on his familiar symptoms, however, was when I sat him up from the Dix-Hallpike position. And if we think about what that means, it means that going from a supine position back up to a seated position triggered his symptoms. If this was BPPV, we would see the opposite. It would be when transitioning into the supine head hanging position that symptoms would come on. So this is the opposite of what we would think of if we were thinking vertigo. So the other factor here is that he had no nystagmus with any of his transitions, which is something I always look for, and no sensation of spinning, just the same whooshing and lightheaded feeling. So next up, I dove into orthostatic testing, because that was my kind of big suspicion from the start, is that this was a blood pressure issue. So in order to appropriately test for orthostatic hypotension, the patient has to lie flat for 5 minutes. Then you take their blood pressure and heart rate. Per the CDC study guidelines, then you have them stand up and you take their blood pressure and heart rate again after 1 minute of standing, and then repeat it again after 3 minutes of standing. The reason for the repeated measure in standing is to see, first of all, how things recover, and also to see if there's a delayed drop in blood pressure. So if you don't see a drop at 1 minute, keep them standing and still take the 3-minute vitals. So when I took Jim's data, his blood pressure dropped from 132/74 to 94/56 during his supine to stand transition, with severe symptoms of lightheadedness, floating, and unsteadiness, to the point where I had to support him and we had to get him sitting down pretty quickly. This is a classically positive vitals response in orthostatic hypotension. And at this point, I know I need to figure out how to help Jim. With this patient population, oftentimes we think, okay, vitals it's kind of the underlying baseline of what's going on, but how do we impact that? With folks with OH, I like to focus on both what we can change right now in this session and what we need to work on changing long-term over the course of our plan of care. So when it comes to what we can change in the short term, we need to focus on 3 pillars. The first pillar is hydration. Then we think about speed of transitions. And third, we think about preloading the system. So when it comes to hydration, Jim, like many of our older adult clients, was chronically dehydrated and was only drinking sips of water in the morning with his numerous medications. I recently went back and counted how many medications he was on when I was seeing him for this, and he was taking 34 medications. And that was like normal to him. So taking only sips of water when your body's trying to process that much stuff is crazy. That is crazy. So because he was chronically dehydrated, his body was having to work so much harder to keep him moving. So that was number one, is we needed to attack hydration. Now when Jim comes in to see me, I literally greet him with a bottle of water because I'm like, look, I know that this is going to help support what we need to do here. He is also now really focusing on his hydration and independently drinking 6 to 8 glasses of water today, which was really a key in our success with getting Jim feeling better. So the second piece of the short-term changes is the speed of transitions. Jim was the kind of guy where he would stand up and just take off to wherever he needed to go. He has like one speed, and it's try to move as fast as possible until your body takes you down. So what this meant was that he was getting his orthostatic symptoms when he was like 6 to 8 feet away from the nearest surface, and that was causing a lot of issues with unsteadiness, falls, and safety. So he and I worked a lot on making transitions more intentional, slowing them down. And the way that we did that was we added a symptom self-assessment in each position. So if he was laying in bed in the morning, he would be laying there and he would just kind of do like a head to toe reflection, like, how am I feeling? Am I dizzy? Am I lightheaded? I'm good. Then he would sit up and he would do that same thing, head to toe. How am I feeling? And then he would do the same thing standing as well. So what this did is it doesn't necessarily change his symptoms, but it forces him to slow down a little bit, which is really key in orthostatics, is making sure that your body has that extra recovery time to get your blood pressure moving in the right direction before you make the next transition. So that's number 2. And then number 3 is preloading the system. When we think about being an issue with blood flow and return, if we can do things to prime the pump, folks are going to have fewer symptoms when they transition. So my favorite things to do to have people prime the pump are ankle pumps, alternating long arc quads with a strong quad set, and then glute sets with a strong glute set. I have my patients do about 10 repetitions of each of these. And if you've been around the older adult crew for any amount of time, you know that we feel like ankle pumps are so often underdosed. But this is a great time to utilize those ankle pumps because we're getting that distal movement going, getting that distal muscle pump, and then creating that movement upward to help facilitate that blood flow return. I have had great success using these 3 exercises to just get people priming the pump, getting the system functioning better, and often they have a lot fewer symptoms than when they transition to standing. Okay, so that's the short-term stuff. We have hydration, slowing down transitions, and preloading the system. Now let's think about the long-term things that we need to be focusing on with these patients. This, in my opinion, falls into 2 different buckets. We have the medical management and we have fitness. So medical management of this really includes all the comorbidities that the patient has on board, as well as the medications that they're taking. This part of managing OH is really all hands on deck in the sense that we have to be communicating with primary care and specialty teams if we're concerned that medications are negatively impacting our patient. And that was exactly what was the case with Jim. He had been seen by cardiac specialists in a variety of health systems that didn't communicate well with one another. And he had his transplant and oncology teams on board as well. Everyone kept trying to manage his symptoms with new meds. And in reality, what that did was it contributed to making him feel worse. So after my evaluation, I reached out to his cardiac and primary care teams first. He, at that point, was taking 6 different cardiac meds every day, and I simply let them know what my findings were and asked if they would consider evaluating his meds to see if a change could potentially help curb his symptoms. They were honestly really grateful that I reached out and were almost immediately willing to see Jim and modify his meds, which helped immensely. We also then got him set up with a clinical pharmacist within the system who now he meets with quarterly to help manage any new medications and ensure he's not experiencing some of the sequela that comes with polypharmacy with as many meds as he is on. So this piece of the puzzle can feel really daunting if you are not super confident in your med management skills. However, it never hurts to ask the question to the prescribing provider. And I have had so many positive, great encounters with specialists and primary care teams because of asking questions like this. And our patients, frankly, feel so supported when everyone on the team is working toward the common goal of getting them feeling better. So then the final piece of the puzzle is fitness. My ultimate goal with gym and with all of my folks with OH is really to help them find activity and fitness as a part of their lives. We know that this condition is related to their body not responding adequately to a movement-based stimulus. This indicates to me that we need to introduce more movement to the system to improve their body's capacity for activity. It took many, many months, but Jim is now somebody who regularly does aerobic and cardio exercise and modified HIIT training independently and in cardiac rehab twice a week. He is also able to do floor transfers without symptoms of OH and is back to working on his vintage cars without any issues. And most importantly, he is back to being active with his grandchildren and great-grandchildren. And honestly, that's the stuff that matters the most to both me and him. So if you have folks who you think might be struggling with OH, step number 1 is you need to identify and quantify using vitals assessment in supine, standing for 1 minute, and standing for 3 minutes. Then you immediately want to attack the short-term variables that you can change, which include hydration, transition speeds, and preloading the system with exercise. And then you're going to make a plan to address the long-term outcomes that are going to make a difference for your patient, which is including working with the medical team to address polypharmacy and other comorbidities, and taking your patient to the land of fitness to get their system working more efficiently so they can also be a success story just like Jim. Thank you so much for joining me today. And if you are looking for more ideas on how to manage complex patients, join us at an upcoming live or online course, which you can find on ptonice.com. Also, click the link below to receive our bi-weekly MMOA digest straight to your email with tons of great clinical tidbits. Can't wait to connect soon.